Good afternoon. I'm Dr. Bian Matawaran. I'm an endocrinologist. I'm here to talk about big problems of small vessels in diabetes, highlighting microvascular complications in diabetes mellitus. Good day. So these are my disclosures. And for today, I'll be discussing to you the significance of microvascular complications, specifically relating to macrovascular disorders. We'll discuss, of course, general recommendations as to screening, glycemic and BP control, and eventually go through specific treatment for each of the microvascular complications. We are well aware of what we call diabetic angiopathy or vascular complications of diabetes, and we usually divide this diabetic angiopathy into two: microvascular complications and macrovascular complications. And for this afternoon, we'll be discussing primarily retinopathy, nephropathy, and neuropathy. But we will be correlating that to macroangiopathy or causes of death and mortality among patients with diabetes. And these, of course, would include cerebrovascular disease, ischemic heart disease, and peripheral artery disease. And this is just an illustration of the general features of hyperglycemia-induced tissue damage. We all know that the hyperglycemia is the main driver for diabetic tissue damage, and this is because of the repeated acute changes in cellular metabolism, as well as the cumulative long-term changes in stable macromolecules. But aside from that, we have to remember that there are genetic determinants of one's susceptibility to a particular tissue damage. Like, for example, nephropathy. There have been studies showing that there is some clustering with regards to family history among patients that may develop nephropathy particularly. But aside from that, we also have to remember that there are independent accelerating factors like hypertension, hyperlipidemia that will modify outcomes, aside from hyperglycemia and genetic determinants. So this is why it's very important that to address diabetic angiopathy, that we control hyperglycemia, but likewise control other factors like dyslipidemia, hypertension, and other risks for cardiovascular disease. And for today, as I've said, we'll be discussing in detail the changes that we see in the retina, the kidneys, and the peripheral vessels causing diabetic tissue damage. And because of this, we all know that hyperglycemia is the main driver for the occurrence of these microvascular complications. So as you can see here, in patients with poorer glycemic control, as what we've learned in both the DCCT and the UKPDS, that for any rise in HbA1c, as you can see in the x-axis, there is a concomitant rise in the relative risk of complications, specifically microvascular complications. And whatever intervention that will eventually lower HbA1c will hopefully also reduce risk for complications. And that relationship we saw not just in the UKPDS for type 2 diabetes and DCCT for type 1 diabetics, but also in the newer landmark trials like the ACCORD, the ADVANCE, and the VADT, all of which showed that any time that you reduce HbA1c by as little as 0.9% in the UKPDS or 0.8% in the ADVANCE trial, manifested into reductions of microvascular complications. And each of that single manifestation of microvascular complications will lead to an increased risk for death and cardiovascular events. As you can see here, the hazards ratio, for nephropathy, neuropathy, and retinopathy, when seen, increases your risk for the primary outcome of cardiovascular disease. So occurrence of one of the microvascular complications likewise increase your risk for cardiovascular disease. And this is why it's very important to look into this relationship with regards to cardiovascular risk and occurrence of microangiopathy. As you can see here, these are the same risk factors that you get for macrovascular events, the same risk factors that you get when you develop microangiopathy, eventually producing cardiovascular events and for some, death. So that is why there is that very important relationship of microvascular and macrovascular complications, and that any intervention addressing hyperglycemia, as what we saw in the table earlier, no, by reducing HbA1c, by instilling metformin or even sulfonylurea, can produce improvement in retinopathy, albuminuria, neuropathy, or any of the microvascular complications. But aside from that, we have to also acknowledge that any BP lowering agents that will lower blood pressure by as much as 10 millimeter mercury also will have beneficial effects with regards to retinopathy and albuminuria. So that if you do not control these microvascular complications, no, if there's one microvascular disease, two microvascular disease, or three microvascular disease, your risk of dying of non-fatal MI as well as non-fatal stroke will increase by as much as twice, as you can see in this relationship, in this forest plot. Okay, so the systemic consequences of microvascular complications affecting the eyes, the kidneys, and the nerves will also be affecting the heart, the brain, the blood vessels, and even the bones. So as you can see, microvascular, and yet the complications will also translate to the big vessels. So with that, we'll go through some general recommendations as to prevent, screen, and eventually treat these microvascular complications. So in this particular table, you will see the general recommendations when to screen, the timeline for screening for all of the microvascular complications for diabetic retinopathy, diabetic nephropathy, and diabetic neuropathy. As you can see there, 5 years within diagnosis for patients with type 1 diabetes and at time of diagnosis for patients with type 2 diabetes. So that's the general recommendation with regards to screening for the three microvascular complications. And as you can see, in the row on the right, the last row with regards to targeted intervention, I highlighted specific points that are common, okay, to all of these microvascular complications, meaning you need to control blood sugar, blood pressure, and dyslipidemia. And we'll go through each of these one by one. So we'll start with diabetic retinopathy. So diabetic retinopathy is a highly specific vascular complication of diabetes seen in both type 1 and type 2 diabetes. We also know that this is the most common cause of non-traumatic blindness in the working class group. Okay, so diabetic retinopathy is an important vascular complication that we only see among patients with diabetes. Okay. So, the relationship of diabetic retinopathy on incident coronary heart disease and heart failure is seen in this forest plot. Again, as you can see, the occurrence of DM retinopathy also predicts the occurrence of incident coronary heart disease as well as incident heart failure in patients with diabetes. So, the ADA recommends that initial dilated and comprehensive eye examination by an ophthalmologist or optometrist be done within 5 years of diagnosis for type 1 diabetics and at diagnosis of type 2 diabetes. Okay, so that anytime a patient you see in the clinic, newly diagnosed type 2 diabetic, then that patient should be examined for diabetic retinopathy. Part of the newer recommendations for diabetic retinopathy is the telemedicine programs that use validated retinal photographs. So a retinal camera or fundus photograph will be enough as a screening test. Those with remote reading can be an appropriate screening strategy for diabetic retinopathy. And these are current recommendations by the ADA. Okay. So this is just a plot of the screening and follow-up of patients with diabetes. As I've said, now this is quite true for all of the microvascular complications. For type 1 diabetes, within 5 years after diagnosis of diabetes, and you should be examined yearly if you have retinopathy, and if not, maybe every 2 years. If you're type 2 diabetic, then at time of diagnosis of type 2 diabetes, then you have to have that first retinal examination. And just the same, it may be yearly if you have retinopathy or every 2 years if you don't. But very important is that for those patients with pre-existing diabetes trying to get pregnant, so that part of preconceptional care. especially during the first trimester, that patient should be examined, no, for diabetic retinopathy. Or even if that patient is planning to get pregnant, that patient should be examined first for retinopathy before you actually allow them, okay, to get pregnant. So counsel on the risk of development or progression of retinopathy. So that's very important to closely follow up throughout pregnancy and for 1 year postpartum patients with diabetic retinopathy that are pregnant or wants to get pregnant. So specific treatment includes laser photocoagulation therapy, indicated to reduce the risk of vision loss in patients with high-risk proliferative diabetic retinopathy, clinically significant macular edema, and in some cases with severe non-proliferative diabetic retinopathy. Another mode of treatment that has proven to be effective is your intravitreal injections of antivascular endothelial growth factor, or your anti-VEGF. So this is indicated to reduce the risk of vision loss in patients with proliferative diabetic retinopathy. So as internists or as non-ophthalmologists, there is a study, this is the field trial, this is the Fenofibrate intervention and event lowering diabetes study. This is basically a study primarily looking at reduction in cardiovascular events. But what we've learned in the field trial is that for those patients who were given Fenofibrate versus that of placebo, you will see that there was a significant reduction or percent of patients needing treatment for diabetic retinopathy. And that reduction is as much as 31%. If you look at the forest plot on the right, you will likewise see that for those patients with no retinopathy at baseline or those who have laser naive, you see that benefit with regards to giving Fenofibrate versus that of placebo. And this held true when they did an analysis of the Accord Lipid and the Accord Eye study. So the Accord is the action to control cardiovascular risk in diabetes. These are patients already on simvastatin, but were randomized into simvastatin plus placebo versus simvastatin plus Fenofibrate. And as you can see in the graph on the left, you will see that those patients with add-on Fenofibrate showed reduction by as much as 40% with regards to the rates of progression of diabetic retinopathy. And on the right, you will see here the forest plot looking again at the benefit of Fenofibrate per person as well as change in the severity of diabetic retinopathy. So these two studies showed benefit of Fenofibrate with regards to retinopathy. So to compare the field trial and the Accord Eye study, it showed that there was improvement with regards to need for laser therapy or 3-step progression in worsening in both eyes with the use of Fenofibrate versus that of placebo. So what about diabetic kidney disease? So again, diabetic kidney disease is basically the new term that we that was coined to talk about diabetic complications to the kidney. So before, we now reserve diabetic nephropathy as a terminology specific to the changes brought about by diabetes. So we also know that diabetic kidney disease is primarily diagnosed in the presence of a long duration of diabetes with albuminuria, without hematuria, and most of the time with concomitant retinopathy, accompanied by slow progressive loss in kidney function or EGFR. So again, you see here the correlation of renal endpoints and cardiovascular endpoints in the newer CV outcome trials, so that anytime there were reductions in cardiovascular outcomes, there were concomitant reduction in renal endpoint. And this graph again shows you that very important relationship of increasing cardiovascular risk with worsening of EGFR. So as you can see here, in patients, for example, with grade 3 or as terminal as grade 5 CKD, you will see that the risk for having events increases. So that shows you the relationship in CKD progression and cardiovascular risk. So these are some of the established risk factors for diabetic kidney disease. Again, you see hyperglycemia is part of those risk factors, as well as obesity and hypertension that we mentioned earlier. Okay? But we also have to remember, so that is why there's that newer term, that there are other causes of CKD in people with and without diabetes. So for those people with diabetes, of course, the primary cause is diabetic nephropathy, but we have to also think of other factors that may affect kidney function, and that would include hypertension and renovascular disease that may be present concomitant with diabetic nephropathy. So that is why it's important that we really know some of the signs that will favor diabetic nephropathy versus alternate renal diagnosis. Okay? So consistent with diabetic nephropathy is persistent albuminuria. You have a relatively bland urine sediment. Now, they're relatively clear except from the albuminuria. You have a normal slow progression of disease or a slow reduction in eGFR. So low eGFR is usually associated with overt proteinuria. Now, other complications of diabetes may be present if you have diabetic nephropathy, and that includes, of course, your diabetic retinopathy. So that you usually see these two microvascular complications together. And again, the duration of diabetes is usually longer. No? So that is why you usually see diabetic nephropathy in patients with chronic diabetes mellitus. However, anytime that there's more severe proteinuria, you probably need to think of other disorders causing the nephropathy. If there's persistent hematuria or active urinary sediment, that may not be diabetic nephropathy alone. If there's a rapid fall in the eGFR or a low GFR with little or no proteinuria. So this is not very consistent in patients with diabetes. Other complications of diabetes not present or relatively not as severe, shorter duration of diabetes, and of course, family history, for example, of non-diabetic renal disease like your polycystic kidney disease and other signs or symptoms of systemic disease. So I think this is a very important slide so as we will not delay eventual referral to a nephrologist when a diabetic patient presents with manifestations on the right, because there could be other concomitant conditions like, for example, rapidly progressive glomerulonephritis. So it's very important that we know this differentiating features of nephropathy. So these are just some of the different pathways and networks involved in the initiation and progression of diabetic kidney disease. So as I've said earlier, aside from hyperglycemia, dyslipidemia is an important factor, causing those changes below: glomerular hypertrophy, mesangial expansion, tubulointerstitial fibrosis and inflammation, glomerulosclerosis, and of course, kidney fibrosis. So I've shown this because there are novel treatment that I'll be mentioning later as with regards to treatment of diabetic kidney disease. This is the conceptual model of the natural history of DKD. So as you see, patients may present with high GFR initially. They may be in the hyperfiltration stage. If they are hyperglycemic, you see in the second line the histopathological changes, and the third line are the clinical changes. Now, you may have microalbuminuria progressing to macroalbuminuria, and eventually complications that would include ESRD as the terminal event of GFR loss. No? Okay, so how do we screen for diabetic kidney disease? So the ADA recommends your urinary albumin should be determined. So that may be by using your spot urine albumin to creatinine ratio. And you may need to measure or estimate your glomerular filtration rate, using a different validated formula. You have to remember that diabetic kidney disease may also present as signs of CKD at diagnosis or without retinopathy in type 2 diabetes. So because I mentioned earlier, most of the time, you have CKD or diabetic kidney disease with retinopathy, but this is usually more common in type 1 diabetics than in type 2 diabetics. There are patients with reduced eGFR now, but without albuminuria, and that is because of early use of RAS blockers. So that sometimes you may have decreased eGFR and yet not that much albuminuria. So we're now seeing that pattern in patients with diabetes. Okay, just a review of the most recent KDIGO, that's the Kidney Disease Improving Global Outcomes. They have a relatively new classification of CKD by GFR and albuminuria categories. So as you can see in this heat map, the GFR classification is graded as to grade 1, 2, 3A, 3B, G4, and G5, corresponding to kidney failure. And the levels of albuminuria will be less than 30 milligrams per gram, okay, as normal, to worst of 300 milligrams per gram at A3. Okay, so that anytime you fall at the red part of the heat map, then it means that you have a very high risk, okay, for renal replacement therapy. Okay, so very important when we manage patients with diabetes that all patients should be examined or tested for a yearly creatinine level as well as urinary albumin excretion and potassium. And depending on the eventual eGFR, estimated GFR, the following should be done. So early referral to a nephrologist for those with eGFR between 45 to 60, especially if there's possibility for non-diabetic kidney disease, which I mentioned earlier. And these are some of the clues used by the KDIGO. Duration of type 1 diabetes less than 10 years, heavy proteinuria, abnormal findings on renal ultrasound, resistant hypertension, rapid fall in GFR, or active urinary sediments on urinalysis. So as you go down, you will see that you may need to test, for example, vitamin D sufficiency, especially for those with CKD, and of course, monitoring other parameters like electrolytes, bicarbonates, especially for those with low GFRs of between 30 to 44. Okay, so what are the approaches in improving outcomes related to DKD? So we've mentioned about prevention of diabetes, of course, glycemic control, blood pressure control, use of RAS blockers, and lipid management. Okay. So we'll go specific to glycemic control because there are some peculiarities aside from lowering HbA1c. There are specific drugs and treatment for sugars that will benefit also the kidneys. Okay, so this is a list from the American Association of Clinical Endocrinologists. We'll just highlight those with effects in the kidneys. There are specific indications and contraindications for treatment. As you can see in the first row, for metformin, it is now recommended that you do not start, or it's contraindicated to start metformin for those patients with eGFR of less than 30. Okay? And we'll highlight some of those medications that will have benefit. Okay. So we've earlier mentioned about the advanced trial and the follow-up trial, and that is the advance on. Because what is very specific in the advanced trial, when they did study both macro and macrovascular complications, it was actually the microvascular complications that showed benefit, as you can see in the forest plot on the left. Now, as you can see here, there were improvement, okay, that favors intensive treatment. Remember, the intensive treatment arm of the advanced trial was glycoside-based, meaning patients were on glycoside, even pushed to as much as 120 milligrams daily, and that intensive treatment based on glycoside shows improvement for microvascular complications. The main driver of which, as you can see, is new or worsening nephropathy. So after the advanced trial, so that strategy showed a 21% relative reduction in nephropathy. They eventually did, okay, a follow-up trial, and that is the advance on trial. And as you can see in the advance on trial, that there was a significant cumulative benefit with respect to end-stage renal disease that was seen even after those patients enrolled in the advanced trial. Okay, so there was that persistence of renal benefit in the advance on trial. Okay, Please do remember that you need to adjust medications, depending on the EGFR. So as you can see here, EGFR or grade 4 between 29 to 15, most of the anti-diabetic medications are not recommended. Okay? So those not in red would include your DPP4 inhibitors. So remember to give the full doses of your DPP4 inhibitor. You only reduce the dose based on the EGFR for sita, vildagliptin, for example, and saxagliptin, and not for linagliptin. You don't need any dose adjustment. Okay? So aside from that, it's very important also to follow the current recommendation of the ADA and the EASD with regards to compelling indication of particular drug depending on the patient phenotype. So as you can see here, in the ADA guidelines, it's still metformin as the first-line treatment. However, you have to assess patients if they have ASCVD, CKD, or heart failure. Mainly because now, for those patients, for example, with CKD, there are now proven therapy like your SGLT2 inhibitor and your GLP-1 receptor agonist showing benefit with regards to CKD. And we saw that in several CV outcome trials for GLP-1. You see that there was some benefit with regards to broad kidney endpoints of new onset macroalbuminuria, sustained doubling of serum creatinine, or a 40% decline in eGFR, ESRD, or death of renal cause, with the use of GLP-1 receptor agonist versus that of placebo. And similarly, you see that more robust benefit with regards to those same outcomes with your SGLT2 inhibitors as well. Okay, so those two agents now has shown a relative risk reduction of the broad composite kidney outcomes by as much as 18% for the GLP-1 receptor agonist and as much as 38% for the SGLT2 inhibitors. And these are just some mechanisms of the renoprotective effects of SGLT2 inhibition. So primarily, what it does is that it decreases intraglomerular pressure. It decreases the pressure in the glomerulus, thus reducing risk for glomerulosclerosis. And they are quite the same with regards to the effect in the intraglomerular pressure, a reduction, a vasodilatory effect in the afferent arteriole by your GLP-1 receptor agonist, as well as in the efferent arteriole, thus reducing intraglomerular pressure. So that's where glycemic control. How about blood pressure control? We all know that this is from the 2018 ESH-ESC recommendation that you have to control blood pressure for diabetic patients, and recommended as initial therapy is a dual combination of an ACE inhibitor or an ARB plus a calcium channel blocker. So the treatment, especially for those patients with albuminuria, should be RAS blockade, either an ACE or inhibitor. And this is just a list of the different ARBs or ACE inhibitors showing benefit with regards to DKD. But very important to highlight the last three studies. This is the on-target study. This is combining ramipril and telmisartan. The Nephron study combining losartan and lisinopril, and a combination of ACE or ARB, because we now know that it is not appropriate to combine an ACE and an ARB. Okay, so do not combine an ACE and an ARB, because of higher risk for renal outcomes, especially so in the on-target trial. Okay. So how about lipid therapy? In the CARDS trial, if you're still familiar with the CARDS trial, that's collaborative Atorvastatin diabetes study, whereby diabetic patients were given 10 milligrams of Atorvastatin. It showed that there was some improvement with regards to the mean within-person change in eGFR. If you compare patients who were normoalbuminuric given Atorvastatin versus those normoalbuminuric given placebo, you will see that there was better or even an improvement in the eGFR. Okay, just a modest improvement. However, what was most apparent was for those patients who were albuminuric. There was actually a less decline in the eGFR for those patients started on atorvastatin that were already albuminuric versus those patients albuminuric but was given placebo. And in the Planet 1 study, these are type 1 and type 2 diabetic patients with proteinuria, 18 years old and above. They were hypercholesteremic, already on ACE inhibitors and ARBs, randomized into 3 groups: Rosu at 40, Rosuvastatin at 10, and Atorvastatin at 80 milligrams, showed primary endpoint with regards to changes in urinary protein-creatinine ratio. It showed that it was significantly lower at 52 weeks than at baseline for the Atorvastatin 80 milligrams versus that of the, these are within, okay, population comparison. Okay, so there was no improvement on that for those patients on rosuvastatin at 10 and 40 milligrams. And similarly, if you look at the secondary endpoints, the mean eGFR at 52 weeks was not significantly different from baseline to atorvastatin 80 milligrams, whereas it fell significantly in the rosu 10 and 40 milligram groups. Okay, and lastly is the changes in albumin excretion in the DAYS study. That's the Diabetes Atherosclerosis Intervention Study. If you look at the number of progressors, not those who progressed with nephropathy or with albuminuria, you will see that there were less patients, progressing nephropathy, okay, in those patients given fenofibrate versus that of placebo, as well as more patients regressing, okay, increased regression of albuminuria for those patients given fenofibrate versus that of placebo. Okay, so there are also novel approaches and emerging therapies that we will be learning in the future, and these are studies on the different mechanisms causing diabetic kidney disease. Okay, and these are the ones listed above, and these are the studies that will pertain and will give benefit for all of those. So hopefully we will be updated on some of these novel therapies for diabetic kidney disease. So last of the microvascular complications is diabetic neuropathy. So diabetic neuropathy is a heterogeneous microvascular complications. There are a lot of presentations of diabetic neuropathy. So these are just some of the classifications of diabetic neuropathy. So you may have diffuse neuropathy, you may have mononeuropathy, and radiculopathy or polyradiculopathy. Of course, the most common of which is your diffuse neuropathy. Okay? So this would include your distal symmetric polyneuropathy, which is the most common type of diabetic neuropathy and is considered synonymous. Okay, we usually call this the classic stocking and glove sensory loss. So this is characterized by progressive loss of distal sensation. So the more distal the nerves are, the more it is affected. So this correlates with loss of sensory axons, followed in severe cases by motor weakness and motor axonal loss. So this is the most important cause of foot ulcers, as well as a prerequisite in the development of Charcot neuroarthropathy, and may be contributory to falls and fractures in patients with diabetes. So the ADA recommends that all patients should be assessed for distal symmetric polyneuropathy, starting at diagnosis for type 2 diabetes and 5 years after the diagnosis for type 1 diabetes, then at least annually thereafter. Okay? So also consider screening patients with pre-diabetes, those who have symptoms of peripheral neuropathy. Why pre-diabetes? Because there's that study, that's the Monica Augsburg survey, looking at the prevalence of distal symmetric polyneuropathy, and you see those bars in the middle, those with IGT and IFG, also presented with some level of neuropathy using the Michigan Neuropathy Screening Instrument, compared to diabetic patients and compared to patients with normal glucose tolerance. Okay, so that is why even for pre-diabetes, you have to examine for polyneuropathy. Okay, so assessment should include a careful history in either temperature or pinprick sensation, vibration sensation using your 128 Hz tuning fork, and an annual 10-gram monofilament testing to assess risk for feet ulceration. And of course, electrophysiologic testing or referral to a neurologist is really needed for screening. Okay. So management of diabetic neuropathy may be symptomatic relief. You may use topical physical treatment, or those treatment may influence natural history. Okay, although the data for most of these interventions are not as robust. Okay. However, the American Diabetes Association came up with a position statement in 2017 as to how to manage painful diabetic sensory polyneuropathy. So if pain is due to DSPN, okay, if yes, you assess for comorbidities and for potential for adverse events or drug interactions of the agent. So as you can see in the algorithm, the first of the recommended treatment will be your pregabalin and gabapentin. Next is your duloxetine or your venlafaxine, and secondary amine tricyclic antidepressant like your nortriptyline and your desipramine. Okay, if there's no meaningful effect, then you can switch to another agent or try combining agents from above. You may also add a non-narcotic analgesic, your tramadol or tapentadol. Okay, and if no clinically meaningful effect was noted, you may refer to a pain clinic. Okay, so these are the recommended treatment as well as the initial doses and effective doses for diabetic neuropathy. So unfortunately, the desipramine and tapentadol is not available in the Philippines. Okay. So there are recommendations. Now, this is from different organizations like the Philippine Neurological Association, teaming up with other institutions to come up with recommendations for the treatment of painful diabetic neuropathy. And as you can see in this recommendation, you see that pregabalin, gabapentin, and duloxetine are the first line treatment, okay, for painful diabetic neuropathy. Okay, and as you can see there, you have your other treatment for painful neuropathy as second tier, topical, and other treatment that lack evidence for any recommendation. Okay, so since pregabalin is the first line treatment, I just want to really tell our co-physicians how pregabalin is given. Okay, so remember that pregabalin is not a PRN pain medication. Hindi po siya NSAID that you give only when needed. So ideally, okay, pregabalin is started at 75 milligrams twice a day. I personally don't use twice a day initially. I usually start at 75 milligrams, but this is the product label. You can start at 150 milligrams or 75 milligrams twice a day, and you may up-titrate after a week or so if there's no response. And you can actually push the dose to as much as 600 milligrams per day. So it's very important that you up-titrate the dose and don't give it as needed only. Okay? So you can push the dose. You tell the patients that there may be occurrence of some dizziness, some may suffer from edema, but for most of the adverse events, they usually disappear after a week or two of treatment. Okay, so they may need to anticipate those occurrence of side effects. What is also very important with the use of pregabalin is that it should not be discontinued abruptly. No, it should be discontinued gradually over a minimum of 1 week. So if you're giving, for example, 600 milligrams, don't automatically or abruptly stop it. You have to taper down within a week to lower the complications of treatment. Okay? And you also need to adjust based on the renal function. So depending on the creatinine clearance, if your patient, for example, is on hemodialysis, okay, you may need to adjust or give a supplementary dose, okay, following hemodialysis in those patients with severe renal deficiency. Okay? So in summary, hopefully I was able to show you that diabetic microvascular complications are primarily driven by the duration of diabetes and glycemic control, and optimization of glycemic control as well as blood pressure has been shown to reduce the risk and slow the progression of microvascular complications. And appropriate screening and specific treatment modalities are necessary to address small vessel angiopathy in patients with diabetes. So that's my last slide. Thank you very much.